Okay, let's move on to my guest. Now, over the past several months, I've talked with a number of Lyme disease advocates concerning their frustration with the, quote, establishment, concerning a slew of issues about Lyme disease. In an effort to hear all sides of the Lyme disease debate, I am now joined by Dr. Paul Auwaerter. He is the clinical director for the Division of Infectious Diseases at Johns Hopkins. He's a professor of medicine with research interest in Lyme disease. Dr. Auwaerter, welcome to the show. Did I say your name correct, sir?
You sure did. Oh, thank you very much for having me.
Excellent. All right, this topic, I mean, I've talked about this several times, and it's the controversy is right up there with the anti-vaccine movement, and as you know, Lyme advocacy is very, very vocal. It's very organized, and they do have a number of grievances concerning some topics surrounding the disease. And out of fairness, I want to get your thoughts as a Lyme disease expert on these issues. So let's go ahead and start with the diagnostics, the Lyme testing, and that's where a lot of complaints lie. And the complaints surround the CDC's two-tier Lyme disease testing process concerning its effectiveness in diagnosing the disease. First, can you explain what the two-step laboratory testing process is, and are these complaints valid?
Well, yeah, this perhaps deserves a lengthy answer, but we'll try to break it up a bit. The bacteria that causes Lyme disease, Borrelia burgdorferi, is a bit different than many customary infections where we can order cultures and find out if you have staph or strep infections or urinary tract infections. So really the diagnosis depends on a couple of factors. Do you see a rash that might be characteristic? That's erythema migrans. And I think everyone feels very comfortable that that's probably a good way to diagnose many cases of early Lyme disease. However, if that rash history is not present and you're in an area where you can acquire Lyme disease from the bite of a infected deer tick, then you're going to depend on what's called serology, or this two-tier test, which is really an antibody-based test, which means you're not detecting the actual infection. What you're detecting is the host, meaning the human response to the infection, so the immune response generating antibodies. So, indeed, the test is not very good in the first couple weeks of infection because the body takes a week or two or three to mount antibodies in response to bacterial infection. So for very early infection, it's indeed not a great test. However, if someone's had Lyme disease for a period of weeks, then the test really does work very well at detecting measurable amounts of antibodies. I can go into some of the other issues or pitfalls or concerns as well that perhaps your listeners have. But, if someone comes in with a swollen knee, or if they have a paralyzed face from a facial palsy, or they have a severe pain like shingles, and you get a test that shows a very high level of antibodies, then I think people would often feel, meaning clinicians, would feel very comfortable linking that to a diagnosis of Lyme disease.
So when the Lyme disease advocates say this is an ineffective way to diagnose, what's your response to that?
Well, I believe that many of the advocates certainly feel unwell, and I'm quite empathetic, and I think they have a number of unmet needs in the sense of trying to figure out why they're feeling ill. But it's been my experience, at least in patients that come to my practice, that many people are suffering from what I would call nonspecific symptoms. So they may have persistent fatigue, they may have chronic pain, they may have sleep that's unrestorative, they may have what's commonly termed brain fog. These symptoms can be caused not only by Lyme disease, but other conditions. But I think what's developed is a group of doctors that sort of have labeled these symptoms chronic Lyme disease without a lot of compelling evidence linking it to authentic Lyme disease. Some people might call patients suffering from this as having chronic fatigue syndrome. Others might call it fibromyalgia. There could be other conditions as well. So I think that's really where I believe the sense is patients who have been told they have Lyme disease based on the say-so of a clinician, but doesn't have testing that's really compatible with Lyme disease. Really, that's the divide. And I think for someone that follows a bit more evidence-based medicine, we sort of look at people that are feeling unwell that have nonspecific symptoms, and there's a whole range of problems that could cause that, not just Lyme disease.
Yeah, I want to go ahead and talk about the Lyme clinicians a little bit later, but I want to continue with another question concerning the diagnostics. And a week or 3 weeks ago, I had a Lyme advocate on the show, and they said there's an alternative Lyme test that's available, and they said it's in only a few labs, a couple in the States, a couple overseas. Are you aware of this test? And if so, is it effective? And if it is effective, why isn't it offered everywhere?
Yeah. So your question gets to a number of issues that perhaps I'll try to break down.
Okay.
First, there are so-called Lyme specialty laboratories, and many of them are offering tests which are called laboratory-developed tests. This is different than Food and Drug Administration approved tests like two-tier serology or the Lyme C6 antibody test. What this means is that if a laboratory develops a test and they only offer it at their single laboratory, it only has to be validated in the sense of accuracy, not clinical validation. So there's really no absolute requirement that these tests be clinically validated. So some laboratories that offer so-called alternative criteria for assessing Western blots or offer what they are called advanced blood culture systems for detecting Borrelia or other methods. These are not necessarily clinically validated, but are being offered by the laboratories, and all they have to do is say that it works in their laboratory and has a certain analytical specificity. So the Centers for Disease Control has actually issued several warnings over the years cautioning against this, and in my own clinical practice, I would say 90+% of patients that utilize these tests, I can't come to a clinically valid conclusion that they have Lyme disease. So I think there is an overdiagnosis of Lyme disease in using these tests. So that's a bit of the cautionary tale because people will get labeled or tested and it could be missing the true or accurate diagnosis. The Food and Drug Administration is strongly considering changes to not allow so-called laboratory-developed tests to be offered without clinical validation. So I don't know what will come of that, but there's a sense that these laboratories may be offering tests that may not truly represent what they state.
Well, let me follow up on that because one of the things they say is I've had these symptoms for 5, 10, 30 years, and they did all the two-tier system, and it always came up negative. And then they had one of these Lyme laboratory tests done, and it came up positive. And finally, I have the diagnosis. What say you? Yeah.
Well, I really can't comment on a particular patient, but I would just say in my general practice, I think many people that feel unwell for a while are searching for an answer. Mm-hmm. People don't want to be told, quite honestly, that they have a syndrome we use in medicine when we don't truly understand the sort of soups to nut process. So, no one likes to be told, well, I think your diagnosis is chronic fatigue syndrome. And that has its own issues because we don't know the cause. We have imperfect treatments for this and so on. So I think when someone suddenly has this so-called eureka moment where suddenly a test states that they have something, again, in my experience, that's often a false hope, a false notion, and I've had patients go on treatment for months or years by other physicians, and then come to my practice and ask why none of these drugs are working, and it's probably because the diagnosis is incorrect based on these alternative lab tests.
Gotcha. Now, they've developed, PCR tests for just about everything. Is there something available for Lyme?
Well, I don't want to be dismissive of all laboratory-developed tests, because certainly there are some that may be promising, and that's the way tests may be further developed. So some caution is needed, but the polymerase chain reaction is a test which has really helped tremendously with detection of viruses. It's really not as good for bacteria, especially when they're not always present in the bloodstream. We did a study some years ago where if we did lots of tests on a patient, if we did a skin biopsy, if we did blood samples, if we did PCR reactions, if we did cultures and we did serology, we could diagnose about 100% of patients accurately. The trouble is most patients don't want to have blood and skin biopsy and blood tests 1 month before and after they have the infection. So there are strategies that I think can help improve the diagnosis. The problem with PCR is there's so few bacteria, and this particular organism doesn't really amplify always as well, that it really has a limited role in diagnostics for Lyme disease at present.
Gotcha. Okay, let me switch gears to another issue of conflict, and that's treatment. And as a Lyme disease specialist, as a expert, as a physician, what is the recommended course of treatment for Lyme disease?
Well, the current recommendations vary a bit depending on what kind of health problems that you have that Lyme disease has caused. So typically, anywhere from a 2 to 4 week course of antibiotic therapy is probably sufficient for the vast majority of people that are diagnosed with Lyme disease. Whether it's early Lyme disease or late Lyme disease, and occasionally the need for an injectable or so-called intravenous antibiotic is necessary, especially when people are quite sick or hospitalized. That said, I think one of the key things I always tell people and try to educate is that when people have Lyme disease, indeed, it is a disease where people can have symptoms that linger after. The fever may be gone, the rash may go away, the joint swelling may subside, but many people are indeed troubled by fatigue and pain afterwards. And I tell them it's a lot like infectious mononucleosis, which some of your listeners may be familiar with, which is caused by a virus. And that virus, although symptoms subside, some people are troubled by fatigue for a month or two. This seems to be the case also with Lyme disease, because maybe a quarter of people are still not feeling completely 100% by 3 months, and even maybe 10% or so at 6 months. So it is something which can truly afflict people, and we'll get into a little bit about people that have these longer-term symptoms and what we can do about them. But basically, people have tried varying the initial duration of treatment and have not found strong evidence that longer treatment makes people feel better faster or more durably.
Yeah, I like I said, I had an advocate on a couple of weeks ago, and I know personally, 3 or 4 people that I've met during the course of my adult life who's had Lyme, and they've went through 2 to 4 weeks of antibiotics. And when I mentioned that, and they said, there's no way. And this is one of the big stumbling blocks between what you say and what they say. The advocates say this is totally ineffective. You need much more antibiotic treatment and all kinds of alternative therapies. How do you respond to that?
Well, maybe in a couple of ways. First, if I thought they truly worked, or if I thought there was evidence, because people have tried treating with longer-term trials compared to placebo. If it looked like there was a signal, I think we would adopt that.
Yeah.
I mean, I only want people to get better. I'm not trying to make life difficult. So when people say they feel better, a couple of key points. In trials of people that have long-term symptoms, and when they're compared to treatment with long-term antibiotics or a sugar pill placebo, there was no difference in any of the 6 trials to date that have examined this. Importantly, at least in one of the larger trials, about the placebo response was about 37%. So when people say they need long-term antibiotics, it's hard to judge because there's no information that says, what you're doing is really better than that placebo response. And I fear that many people feel that. The second thing is that people who do have lingering symptoms after Lyme disease, studies have suggested that over time people revert to baseline. And that's what studies have suggested. It can take a while, and I am absolutely someone that wants to try to get people feeling better faster. But I don't feel antibiotics are probably the right way. The last thing I'll mention for your readers is, there was a recent study called the PLEASE trial in the Netherlands that was published in March in the New England Journal. And that study came about in part because many advocates wanted to say, well, look, you weren't using the right antibiotics, you weren't doing the right treatment and so on. So that really compared placebo versus doxycycline versus clarithromycin and hydroxychloroquine. And let me tell you, the reason those researchers chose those drugs were based on 2 studies by Sam Donta, which were observational studies done in the United States and New England that suggested that there was a tremendous response when people got long-term doxycycline or got long-term hydroxychloroquine and clarithromycin. So that's why they developed the trial. But they developed it as a prospective randomized trial, the so-called gold standard, whereas what Sam did was a so-called observational study. So they designed their whole study around this concept, and at the end of the day, what happened again is that there is no difference between those 2 antibiotic arms or receiving placebo in terms of how people felt. So at the end of the day, it does not seem likely that antibiotics are going to help people feel better if they truly have had Lyme disease as a cause for fatigue or pain that's really persisting. So we really have to look into other arenas, and I'd be happy to elaborate a bit on that.
I'll give you another minute and a half if you'd like to.
Sure. Well, so there's some increasing evidence done with more sophisticated molecular techniques looking at how genes express themselves in others that really show that after Lyme disease seems to provoke a very different set of patterns of genes in human responses compared to traditional infections. So many of us think that there is probably some driver, whether it's the debris of the bacteria or something that has sort of changed how immune systems work. It seems to activate what we call the early or the innate immune system, and perhaps because this is triggered and perhaps vigorously in certain individuals, it seems to be clicked into a different position that persists over time. So if this is true, then it would be trying to understand why that's happening and then what kind of treatments might be able to help staunch fatigue. I remind people that Lyme disease is not the only infection that causes a post-infectious fatigue syndrome. There are viral causes like infectious mononucleosis. If you're in Australia where there isn't Lyme disease, Q fever is another one that about 10% of people have a persistent fatigue syndrome after acquiring infection. So there's probably some commonality that we don't yet understand well, but with advancing knowledge, perhaps we can develop some interventions.
Well, excellent. Dr. Auwaerter, can I get you to hang on for the second half? I got several more questions for you.
Okay.
Oh, excellent. All right. Well, the website is outbreaknewstoday.com, and when we come back from the break, more about Lyme disease with Dr. Paul Auwaerter.
Outbreak News this week. Your source for all the news about worms and germs. Here's your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, welcome back to the show. I am joined by Johns Hopkins Professor of Medicine, clinical director for the Division of Infectious Diseases, and Lyme disease expert, Dr. Paul Auwaerter. Okay, Dr. Auwaerter, let's go ahead and here's a question that many advocates say that people like you would deny. Is there such a thing as chronic Lyme disease?
Well, the way it's framed, I would say, makes it sound like I'm trying to be dismissive, and I'm really not. I would say that chronic Lyme disease is an imprecise term. Certainly Lyme disease can present late, like with a swollen knee, so we tend to use a term like late Lyme disease. We already talked about how some people have lingering symptoms after treatment of Lyme disease, which, if it really persists beyond months, like 6 months, we'll call it post-treatment Lyme disease syndrome, which really is a post-infectious disease syndrome, as we talked about before the break. The issue with chronic Lyme disease is I'd be happy to call it chronic Lyme disease, but what I find is that certain practitioners tend to use it rather liberally to diagnose people that are feeling unwell, that have complaints that aren't well understood, and really don't have lots of what we would call objective or indications that they've been actually infected with Borrelia burgdorferi. So it's not that I deny that chronic Lyme disease exists, but what I would say is that using this imprecise term, I think, blurs distinctions, and unfortunately many people are not well served by that term, and maybe not obtaining a correct diagnosis or being exposed to significant amounts of antimicrobials with really no real benefit compared to what maybe time alone or other methods might help them.
So how do you explain this phenomenon then, that all these millions of people, I mean, if I post a story on the website, I mean, I get inundated from Lyme advocates, and there's a lot of people out there. So they're not just imagining what they're going through.
Oh, absolutely not.
Right.
Really, I am not trying to be dismissive or anything like that. I think.
No, I understand.
Everyone that I see in my office that does come in saying, well, I have chronic Lyme disease and my treatment's not working, or what can you do for me? Those people are all suffering, and I try to help sort through it. So that is not something that I take very lightly at all. But what I think has happened is, as I said earlier, no one really likes a syndromic diagnosis. Doctors don't, patients don't. I mean, it means we really don't understand the cause, but we're constructing things on a clinical framework. So, fatigue and pain are common problems as people enter into adulthood and age. So if you look at most population studies, these are fairly common, and for many people it's quite debilitating and interferes with work, their family life, lifestyle. I think the reason it's gotten a lot of traction is because it's been popularized by certain sectors of the alternative medicine community as a cause for this. And indeed, as I mentioned, it may be for a small segment. Lyme disease is an authentic cause of persistent fatigue and pain. But I think for many people it's not. Over the years, at least in the United States, a variety of diagnoses have been pitched as a cause for chronic fatigue and pain. If you go back to the 1920s and 30s, chronic brucellosis was advertised as a cause. Indeed, it can cause pain and fatigue despite treatment. But it really didn't pan out when people looked at it carefully. In the 1960s, after the discovery of Epstein-Barr virus for infectious mononucleosis, chronic Epstein-Barr virus was popularized as a cause. But again, studies have not really found that to be a clear link and driver for fatigue and pain in the majority of people. For a while, chronic candidiasis was popularized based on a book. But then a trial that eradicated Candida compared to placebo found that despite clearing the Candida, there was no improvement more than placebo in patients receiving fatigue. So I think Lyme disease has stepped in as in that line where people are searching for answers, and certainly, having a microbial explanation for this, everyone would love, because then you could target it and treat it. But the trouble is that at least antibiotics don't seem like the right answer if you are authentically infected with Lyme disease and still feeling ill. And then for people that really don't have Lyme disease, they might be misdiagnosed and therefore not receiving the best therapy.
Yeah. Let me ask you another question about therapy and the bacterial structure of the Borrelia. I've asked Lyme advocates in the past, I would say, why do you say this is so hard to treat? It's a spirochete. Other spirochetes, one shot of penicillin is going to take care of treponema. Is there a bacterial structural difference between Borrelia and, say, the treponemes, which would make it harder to treat?
Well, no, since it lives in an animal reservoir, there's really not any antibiotic resistance that we know of, so that's not an issue. Certainly, the Borrelia, much like spirochetes, there may be occasional instances where, despite treatment, there may be some organisms that are dormant and revert. We know that in syphilis, right, despite treatment. Mm-hmm. So I wouldn't be surprised that can be an occasional problem in Lyme disease. The trouble is, despite pretty exhaustive efforts at trying to understand if infection comes back, that has not been well documented for it. Now, Lyme disease is a fairly complex organism in the sense that it has a lot of plasmids and genomic information that makes it a bit bulkier and probably legitimately more complex in the sense of many other bacterial organisms. But I always step back and say, from a biologic plausibility stand, as you had mentioned, we think the antibiotics work pretty well at causing what we call a microbiologic cure. What it's not very good at is really the clinical cure, in the sense that there are a minority of people that still feel ill despite the antibiotics. So I think the fundamental understanding is to try to understand why that's happening. Really, there is not a lot of evidence to suggest that bacterial persistence plays that role, and additional antibiotic therapy really hasn't added up to date. So I think there are probably different strategies there, but it doesn't seem like there's some kind of intrinsic resistance or something that truly differentiates it from other bacteria, at least in that regard.
Okay. Now, other than tick bites, are there other vectors or other ways other than vectors to contract Lyme?
Well, it doesn't seem to be a cause of blood transfusion disease, as far as we can tell. That's really not been reported. I would say that so-called transmission across the placenta to children, to fetuses, does not seem to be a significant issue. And so-called sexual transmission, which has been advertised on the internet, again, I think anything's possible, but it does not seem to be anything that I would term a common concern or fear for people. Some people do come into my office and say they're very concerned about transmitting it to their family or partners, but I think the main concern remains, good tick prevention strategies at this time, since we really don't have a vaccine at the moment as a prevention strategy.
A few years ago, the CDC came out with an estimate saying about 300,000 cases of Lyme. Do you subscribe to that?
Well, that was based on health claims data, and I'd say that it's probably a reasonable point estimate. Okay. Health claims data are always tough because, as a doctor, I certainly see people put down diagnoses so that lab tests get performed, but that doesn't mean it's actually what someone has. Yeah. So personally, I think it may be an overestimate. But what we know from public health reporting, remember, I think there's a criticism that the CDC hasn't really captured all the cases, and that's not really the goal of public health reportable diseases. It's really to identify trends. We know from syphilis, we know from gonorrhea that generally only about 10% of cases are reported. So if there are about 30,000 cases in the United States reported annually, a reasonable multiplier would say that 270,000 or even 300,000 may be actually true because only 10% of cases get reported. So that's why I say I wouldn't fight hard on that. I would say the methodology is tough because they were using insurance claim data.
Okay. Now, let me see. It was about 5 years ago. I dug this up on the internet. It's a personal view that you published on the Lancet, and you pointed quite a few fingers at this so-called Lyme literate medical doctors. What is your complaint with them, and do you consider them opportunists?
Well, the reason we wrote that is mainly because I've seen really many patients come into my office where I fear they've really been on the wrong track, misdiagnosed, and really mistreated. And as the article points out, many of these so-called Lyme specialty physicians have had a number of issues that I think many people would say wouldn't place them as a typical ethical physician. So that's what that article portrayed there.
Would you say that's the same 5 years later?
Well, I haven't gone back. That required a fair amount of research and grounding.
That's true. I saw all the references used.
Yeah, I mean, this was not a lightly done piece by any stretch of the imagination. And again, I have no trouble with the patients. I have no trouble with the advocates. These are people that feel unwell. They want to try to, advance the field. I'd like to do that as well. I think the physicians that use them, opportunists may be the right term potentially for some of the patients. I will say patients like them because they often, spend a lot of time with their patients because they don't accept insurance often and do charge higher sums of money. And patients want to be heard and cared for. So, I think there is certainly a role for that, and I think probably our own modern medical system traditionally doesn't do well with people that have chronic fatigue or pain or brain fog and so on. We're not very good at sorting through that, and certainly not in a 10 or 15-minute visit.
Gotcha. All right. And also in your personal view, and I've heard advocates tell me this. I get lots of emails, and they say that people that disagree with them, they call them anti-science, and that was sort of mentioned and implied in the personal view. Do you still stand by that?
Well, I do, at least for the physicians. As I said, if I thought there was credible evidence that long-term antibiotics worked, or that most people that have fatigue or suffer from Lyme disease, I'd follow that path. But I don't believe that to be fundamentally true. So, I think physicians that may call themselves Lyme specialists, perhaps many of them don't subscribe to that, and in fact have developed their own theories and practices, which, as far as we can tell, in the current system, really aren't backed up by sufficient credible evidence to really endorse their practices.
How long have you been treating Lyme patients?
So, since 1996, I started a clinic in Baltimore County in the suburbs, where I thought I was going to see infectious diseases generally, and quickly my most common consultation request was for Lyme disease.
Okay, and my last question, I want to let you go. Your day-to-day, what's your personal experience with Lyme patients, and do you get some of these advocates that debate with you or anything like that?
Well, I certainly I don't really wish to debate. I mean, I think if people come with a certain point of view and they've done their own research on the internet and come to the conclusion that they really should be treated, I'd say 20 years ago I did have some people like that in my office, but nowadays I think with the amount of descriptions on the internet, patients may have already come to a diagnostic conclusion and seek out doctors that reinforce that perhaps, or at least will evaluate them. So I tend not to get into much debates. I usually see people now who really have, I see people who have authentic Lyme disease, of course. I see people with other infectious diseases. But for the patients that, might be similar to problems that many Lyme advocates are suffering, I see them in my office mainly because they've exhausted their resources. They don't have funds anymore, or they don't feel like the antibiotics after months or years have helped them, and they're wondering what to do next. So that's the people I see mostly nowadays, and try to see what we can do to help them.
In your experience with these patients, is it the 2 to 4 weeks of antibiotics and doxycycline, I imagine? What percentage is successful?
Well, it depends. So for people that don't have Lyme disease, I would say it's not very successful.
Right.
For people who have Lyme disease, then, as I said, I think, up to a quarter of people will have lingering symptoms. I think that does drop down to 10% or so, plus or minus, at 6 months. And, that's where I'll use some alternative strategies. Unfortunately, what I tell patients are that I know that trials of long-term antibiotics haven't helped, and then they say, well, what does help? And I say, well, unfortunately, there have been 6 trials of antibiotics, but not many other trials to date. So I tend to borrow strategies from approaches that have been developed to treat the Gulf War syndrome or fibromyalgia or chronic fatigue syndrome, or have them evaluated for sleep disturbance, or if there are some components of anxiety and depression that are undertreated. I mean, I'm not trying to make blanket statements. I'm just saying I try to individualize it for a patient and give them some options, see what resonates with them, and then try to take some next steps. But I always want to finish by saying I think an accurate diagnosis really best informs treatment. Given whatever our limitations are in medicine, having the best possible diagnosis really helps then inform what treatment options you should consider.
Excellent. All right. Well, thank you, Dr. Paul Auwaerter, for your time and expertise, sir. I appreciate it.
Thank you very much for having me.
You bet.